Great. So welcome everyone to the Cardiac Amyloidosis discussion group. We try to do these quarterly and just to kind of gather, share our recent insights and hear from you all as well. So thank you for joining us. And Steve, did you want to start off with some introductions?
Well, of course, you already know Margie and Dr. Marr. I'm the person that you get emails from, and you'll always know it's me by my handle SH2669. And I'll be giving you ideas about different events that are going on, webinars, meetings, and these events that we put on, and occasionally special mailings. And some of you may not have met Dr. Watts and Dr. Brailovsky, who won't be able to join us today, but Dr. Brailovsky is the latest member to join our team, and we welcome you them both. And
Yeah, Dr. Brolowski's had a baby on Friday, by the way. So that's congrats to him, and he's enjoying his new addition.
okay, Margie, I'll monitor the waiting room.
Okay, great. Thank you. Yes, and Dr. Watts is working inpatient, so he may hop on later to join us if he's able to. So just to review, this is going to be the meeting structure, which has been the case for the last few meetings that we've done, but we're going to start with just a didactic session, which is just an overview of amyloid, just, some kind of high level basic information just to sort of set the stage. And then we'll go into our Q&A session. Some patients did already submit questions, which is great. So we'll get to some of those, and then you can all ask your questions in real time as well, either in the chat function, or you can raise your hand and we'll unmute you if you want to ask on camera. So that'll be the setup. So again, the theme for this session is, general information about amyloid and then updates in the treatment of the condition. So we're going to talk about our ongoing and upcoming clinical trials and what's new in terms of approved therapies and what we're anticipating. So just to start, what is cardiac amyloidosis? So cardiac, of course, means the heart, and amyloidosis is a term which refers to the process when a protein falls apart and causes fibrils, and these fibrils get stuck in tissues and organs where they don't belong and cause dysfunction. So it's a general term. It's implicated in a lot of different disease processes, but in this session we're talking about when it happens to the heart. So there are two predominant types of cardiac amyloidosis, and they are light chain or AL amyloid and transthyretin or TTR amyloid. And then TTR is broken down further into either hereditary or genetic, or wild type, used to be called senile TTR. So here's just another visual of how this is broken down. So again, cardiac amyloidosis is kind of the umbrella term, and then it can either be ATTR, which is transthyretin, or AL, which is light chain, and TTR, again, further broken down into wild type or hereditary. So sometimes we do get the question, can my children inherit this condition? And we do send genetic testing on all of our amyloid patients just as a standard of care, but the only type that it has any potential to be passed down to future generations is if you have hereditary TTR amyloid. So again, light chain amyloid and wild type amyloid, as far as we know, are not hereditary. So this is just a kind of another way to look at it, the two types of amyloid, and we'll kind of zoom into each of these to get some more information. So light chain cardiac amyloidosis is a plasma cell disorder. So, plasma is in the center of your bones, and plasma cells make antibodies or immunoglobulins that fight infection. And immunoglobulins are made of two light chains, which are kappa and lambda, and two heavy chains, And these plasma cells produce, in light chain amyloid, plasma cells produce an abnormal protein. So the light chains are what's becoming misfolded and causing the amyloid fibrils. Transthyretin cardiac amyloidosis is brought about by a protein called transthyretin. And this is a little transport protein that's made in the liver, mostly in the liver. A little bit is made in the brain and behind the eye, but the large majority in the liver. And it's a transport protein that moves around thyroid hormone and retinol, which is vitamin A. And due to either aging, which is the case in wild type, or a genetic mutation, which is the case in hereditary amyloid, this protein falls apart and causes these amyloid fibrils. And then these fibrils, again, are getting stuck in the heart and other tissues and organs. And then this is just a slide to say, some patients do have a hereditary type of amyloid, and the genetic testing will tell us, what their genetic abnormality is that's causing the TTR amyloid. There's all different, there's many different variations of this. The most common is V122 ILE, which is on this side here. And depending on the mutation, patients can have either more neuropathy or more cardiac symptoms, but for the most part, most patients have a combination of both. So how does amyloid affect the heart? So in this process, again, these fibrils are getting stuck in the tissues of the walls of the heart. So the walls get thick and stiff, and it actually causes the ventricle to have less room inside. So these walls are getting thick, the ventricle is getting smaller and holding less blood. So because of that, less blood is pumped with each beat, and that can cause a heart failure syndrome. So that can manifest with swelling in the legs, swelling in the belly, shortness of breath. Some patients can develop low blood pressure over time. Patients have, feeling of lightheadedness or dizziness, symptoms of poor circulation, like cold extremities. So these can all be symptoms when it's affecting your heart. And these fibrils can also disrupt the conduction system of the heart. So a lot of patients do end up with what we call arrhythmias or irregular heartbeats. And, atrial fibrillation is extremely common in this condition, and that's just one of the manifestations. Sometimes patients can have pauses where their, heart basically is stopping or skipping a beat for a prolonged period of time. And sometimes these complications can lead some patients to get permanent pacemakers implanted, and that helps with some of the conduction issues. And, being, obviously Dr. Ward, Dr. Watts, Dr. Berlovsky are cardiologists, heart failure specialists, so we do spend a lot of our time focusing on the heart. But this is, a systemic condition and can affect other parts of the body, and there can be other symptoms. So just to explain the different manifestations that you may see with cardiac amyloidosis. So we kind of talked about a lot of the cardiac manifestations already, but a huge, very common system that's affected is the musculoskeletal system, particularly in TTR or transthyretin amyloid. Patients have a lot of orthopedic manifestations. And we think this is because the protein and the fibrils, really adhere to ligaments and tendons, parts of the body that are moving a lot. So some things that we see commonly are carpal tunnel syndrome, lower back pain, or lumbar spinal stenosis. Sometimes there'll be ruptured tendons, particularly the bicep tendon rupture. So in your upper arm here, there's a lot of knee, shoulder, hip issues. A lot of joint replacements are very common in this patient population. And then trigger finger, a lot of patients have that as well. So those are some common musculoskeletal manifestations. I would venture to say most of the patients on this call right now have had at least one of these. If you have TTR amyloid, or, if not, you're lucky, but they're definitely pretty common. Another system that's affected a lot is the nerves. So polyneuropathy, particularly if you have a hereditary or genetic type of amyloid, the amyloid can deposit into the nerves of the body. So this may manifest with numbness or tingling in your feet or in your toes and your feet and your legs, and it sort of moves upward from there. So this can lead to difficulty walking and ambulating, and unfortunately sometimes falls. So we do, especially if you have a genetic type of amyloid, we do work closely with our colleagues in neurology to make sure that we're monitoring this and doing testing periodically to make sure that the neuropathy is stabilized once you're on the appropriate therapy. Patients also have autonomic dysfunction. So this is when the autonomic or automatic nervous system of the body gets dysregulated because of amyloid infiltration. So this can manifest with inability to regulate blood pressure. So we call this orthostatic hypotension. This is when when you get up from bed in the morning and you first stand up, you kind of feel like, your blood is kind of rushing to your feet. It takes a minute. You might get dizzy or lightheaded when you first get out of a chair or out of your bed or even out of the car if you're sitting for a long period of time. So that is not uncommon. And, another thing that we see a lot is patients getting intolerant to their blood pressure medications. So as where in the past you might have been on a lot of medication, antihypertensive medications, we call them. So medications to control your blood pressure from getting too high. A lot of times over time with amyloid, your blood pressure becomes lower because, again, the heart isn't pumping out as much blood. So sometimes we're peeling back those blood pressure medications because patients are not tolerating them as well. The gastrointestinal system is also sometimes affected. So this can result in, diarrhea, constipation, weight loss over time, nutritional deficiencies because you're not getting, enough nutrition orally. So again, we do work with our colleagues in gastroenterology sometimes to kind of see what we can do to combat some of these gastrointestinal manifestations. Erectile dysfunction can also be common due to the effect on the autonomic nervous system. So moving on into treatments for cardiac amyloidosis. So thankfully, we've come a very long way over the last, 5 years or so in terms of therapies for this condition. So we're going to get into approved therapies first. So with AL, light chain amyloid, again, the landscape for this disease has really evolved so much over the last 5 years in the positive direction, thankfully. Initially, the main name of the game was stem cell transplant. That was kind of what most patients, if they were eligible for, would undergo. Now, that is still something that some patients do go through, but a lot of times patients are, too affected by the condition. Their heart, is maybe not strong enough to undergo a stem cell transplant. It's a very intense process. So now we do have different therapies that are available, and most of these have been taken from the treatment of multiple myeloma, since it is on that spectrum. So the main therapy that has really changed the game has been this daratumumab. So most patients get a combination of Cyborg-D plus daratumumab, which is a monoclonal antibody, and that is thankfully very effective. So that is typically the first-line therapy for most of our patients, especially if they're not eligible for stem cell transplant. And these other therapies that are listed here, most of these come into play when you're having refractory disease. So patients aren't responding to the Cyborg-D daratumumab combination or not eligible for a stem cell transplant. Then we move on to other options. Venetoclax, is used a lot. Patients are now undergoing at times CAR T cell therapy is becoming, we're getting more experience with that, and the effects are, very successful, which is amazing. And then now, the big category that's being utilized for patients who are having relapsing disease are bispecific antibodies, which have again had 88% response rate here. So seem to be well tolerated, a good response rate. So again, a lot evolving in this field, and Dr. Moore will talk about some clinical trials that have been taking place as well. But lots of options for, if the disease does come back or is not responsive to initial therapy. And now TTR, cardiac amyloidosis, this has been, again, a very exciting time. There's a lot going on, a lot new therapies, coming about on the horizon, and, in the last year, even coming on the stage. So we'll talk more about these. This is a figure kind of showing how, where in the process of the disease, the different therapies are coming in. So we can refer back to this figure. But again, the liver is making the protein. So some therapies are going to start right here where they're actually just stopping the liver from producing the protein. If the protein's already been produced, it's falling apart. So some medications are coming in here and stabilizing the protein. And then further down the chain, if we're already getting to the point of amyloid deposition, we're now in the investigative stage of, medications to potentially remove amyloid fibrils. So Dr. Moore will talk about clinical trials for that, but I'm just going to discuss approved therapies. So the one that I think, patients here are probably most familiar with, if you have TTR amyloid, are the stabilizers. So this is the first approved therapy for TTR amyloid was tafamidis, Vyndamax or Vyndaqel is the brand name. And now just recently in the last few months, Attruby or acoramidis was approved. This is another TTR stabilizer. So again, these medications are stabilizing the protein to slow down the progression of the condition, to keep the protein together and prevent it from forming more amyloid fibrils. These medications are oral. Tafamidis is taken once a day. Attruby is taken 2 capsules twice a day, and they're both, very effective in impacting the morbidity, mortality of this condition. So they're very well tolerated, not much in terms of side effects at all. So these continue to be a mainstay of treatment. The next category of approved therapies are the TTR gene silencers. So again, these medications are actually going to the liver and shutting off the production of the protein. So there are 2 silencer medications that are utilized in TTR amyloidosis. So this vutrisiran or Amvuttra and eplontersen or Wainua. Both of these have been on the market for a while in the treatment of polyneuropathy related to hereditary amyloidosis. So if patients had a gene that was causing the TTR amyloid and it was proven to be in their nerves, then they were, eligible to receive this treatment. And we've been, for the last couple of years, have been investigating these therapies to get the indication for cardiac amyloidosis to see if they had the same positive effects on the heart as they do on the nerves. So very recently, and I think actually some participants on this call participated in our Helios B trial, and that was testing Amvuttra or vutrisiran in the treatment of cardiac amyloidosis, and that was positive, which was amazing. And this led to the expanded approval for Amvuttra for our patients with cardiac amyloidosis. So now you no longer need to have a genetic type. You don't need to have it proven to be in your nerves. If you have cardiac amyloidosis, this is a potential therapy that you could receive. And then Wainua or eplontersen is still being studied. Again, some patients, I recognize on this call are participating in this study as well, which is CardioTransform, ongoing, finishing up. And so we should know if this medication will meet its endpoint and will have the expanded approval as well. So Amvuttra, just to talk a little bit about it, it's an injection it's a small needle that goes subcutaneous under the skin. So you can either get it in the back of your arm or on your thigh, in your belly. And this is every 3 months, every 90 days. You do have to get it injected by a healthcare provider and a healthcare healthcare facility. So that's been, kind of the main issue in terms of navigating this for patients. They have to either come to our infusion center to get it or, some kind of doctor's office to receive the injections. Wainua, which again is not yet approved for cardiac amyloidosis, but if it is in the future, this is a monthly injection, but it can be given by the patient to themselves at home. So that's what we have in terms of approved therapies. And I just, we would be remiss if we didn't mention, the therapies, of course, are life prolonging, life saving, and it's very, very important for patients to be adherent to their medications. But there's so much that is done outside of medications in terms of managing this disease process. So we do like to emphasize, patients can really positively impact how they function and how they do by taking care of themselves, and that includes diet and exercise. So diet, we emphasize a low salt diet because if your heart is affected by this condition, your body is in a salt avid state. So whenever you eat something that has a high sodium content or just some added salt to it, your body is going to hold on to that salt and water. You're going to feel bloated, swollen in the legs, swollen in the belly. You might have more difficulty moving around. You'll see the scale numbers going up, and that usually indicates that you're retaining extra fluid. So we do like to emphasize, less than 2 grams a day. Kind of the lower the better. Some people are outstanding, at this, and, patients, when they first start doing this, I will say, like, I think it makes a bigger impact than they probably thought it would, just monitoring the salt in the diet. So you can feel much better if you're really being vigilant about that. And unfortunately, that usually does mean minimizing eating out, getting takeout foods, because you just, you can't control the salt content in those scenarios. And then secondly is exercise. So we do get a lot of questions about, should I exercise? Should I, just take it easy, whatever. And of course, we want you to listen to your body and not overdo it, especially if you're, feeling dizzy or lightheaded, listen to yourself, listen to what your body's telling you in terms of pushing it. But we definitely want patients to stay active. And this includes a mix of aerobic and anaerobic exercises. So walking is amazing. Anything that you really enjoy doing. So it can be stationary bike, elliptical, treadmill, walking outside, swimming, just to, keep that aerobic capacity up. And then anaerobic, meaning some light weight bearing exercise, is great for maintaining your muscle mass. So this can be working with a trainer, using light weights, using body weight by doing isometric exercises like push-ups, planks, wall sits. There are things that you can certainly do in your home. YouTube has a lot of at-home exercises. If you're able to, you can have a physical therapist come to your house. A lot of patients, go to a rehab center just to have the, the structure and the accountability. So definitely encourage you all to keep active, keep your body strong. And then, of course, following up with your care team regularly. So that was just kind of an overview background information that hopefully was helpful. I am going to turn over to Dr. Moore to talk about some exciting stuff in terms of clinical trials, current, ongoing, upcoming, and, all that good stuff. So Dr. Moore.
Thanks so much, Margie. I did want to recognize my colleague, Karan Watts, has been able to scoot out of the ICU and join us. I don't know, Karan, if you wanted to say hello to everybody.
Hi, everyone. Thanks for joining. It's great to see everyone on Zoom. Hopefully, this is a fun and a good session for everyone, and we're able to answer all your questions today.
Great. And hopefully Karan and I will be able to address questions along with Margie soon after. So maybe I can tell you about some recent clinical trial results, ones that we're doing, and most importantly, spend some time talking about for transthyretin amyloid, which is what a majority of the people on the call have, the 3 available agents and how we're thinking about each of them with regards to, I think, what patients ask often, which is, which one should I take? Which one's better? The short answer is nobody knows, but I'll explain to you hopefully a little bit further why we have some uncertainty. So next slide, Margie. Yeah. So in the world of antibodies, which is very exciting to both us and most patients, the idea that you could remove amyloid from an organ and hopefully reset the structure and function of that organ. In the world of AL or light chain amyloid, there were two antibodies that were developed to treat this condition. Several patients on the call may have participated in some of these studies. Unfortunately, the first one called baritinimab, which was also known as NEOD-001, was studied in a trial, just background, called VITAL, which was done several years ago. And that trial was neutral or negative, did not meet its endpoint. But they did find a signal in which patients who had the most advanced form of cardiac AL amyloid, what they call stage 4 disease, had a clinical benefit in terms of actually surviving longer. And so, even though that wasn't the primary hypothesis, that was a subgroup that was described. The FDA said to the company, well, if you can reproduce that finding over again in a group of patients with the most advanced form of amyloid, we'll approve the drug. And unfortunately, we learned about 2 weeks ago, just as a report in the news, that what was called the AFFIRM-AL trial failed to meet its endpoint. The drug was neutral on its effect with regard to survival for patients. There is another drug called ansilinimab, which is also known as KL101, and that trial is completed. Patients have participated at our center, and we're waiting to hear, hopefully in the next few days or weeks, about whether or not that study was effective. But these are the drugs that were designed to treat light chain amyloidosis and try to remove amyloid from the various organs. And as you can see, unfortunately, at this point, we don't have a positive trial. So this therapy remains in question. Next slide. This is somewhat of a complicated slide, but there are trials here that are noted that are therapies that are accruing. We're getting better and better at TTR amyloid, and especially for those who have a genetic variant that could lead to disease in a first-degree relative, mother, father, sibling, child, or so forth. Remember, it's an age-dependent disease, so most people who have the gene don't develop disease until they're, depending upon the mutation, 50 or 60. But we now have a prevention trial in which acoramidis or Attruby is being tested in patients who carry the gene that could predispose them to develop amyloid. And if they're within 10 years of the time where their relatives develop disease, they can enroll in a trial to determine whether or not we could prevent the development of disease. There is highlighted down in red trials with regards to gene editing. The trial is called Magnitude. This is what we call using CRISPR-based therapy, which is a little scissor that kind of cuts the TTR gene and stops your body and your liver from producing it in the long term. Similar to what we do with current drugs, like Margie mentioned, that are pharmacologically administered, meaning under the skin, but they have to be done repeatedly. This is a permanent stoppage of the production of transthyretin by the liver. And then there is antibodies that are coming and some in testing for TTR amyloid. And several people maybe on the call are participating in what's called the Alexion trial. This is a compound that could, again, potentially activate cells in your body that could chomp up or remove the amyloid from organs. Even though the antibodies in AL, at least to date, aren't effective, we have antibodies in TTR, and we still have great hope for them. Next slide. So this is the Magnitude trial, just to tell people about it. It's a trial involving a company called Intellia Therapeutics. They have developed a CRISPR therapy. CRISPR was something that won a Nobel Prize about 2 years ago, and it's a technique that, again, uses a molecular scissor to cut the gene that could produce a particular protein. In the cartoon that's in the panel B up here, you can see there's a little blue particle up top. That's called a lipid nanoparticle, and inside of that is the scissor, the CRISPR, and also what we call a TTR specific guide. So the lipid particle is taken up by the liver cells or hepatocytes and basically finds its way inside the nucleus of the cell on chromosome number 18, where the TTR specific guide is basically going to bring the scissor to the right spot and cut the genome there. And you can see in the panel at the bottom right where it says a percent change in serum TTR, there is a group of patients, 36 of whom received the therapy. And at baseline, their TTR was a certain level. And within 1 month, the TTR levels plummeted. And there was no further therapy administered, and the TTR levels remain low. And this has been a very well tolerated therapy in the phase 1 trial. And now there's a phase 3 trial. Phase 3 is the stage of trials prior to it getting approved and being on the market. And this is a trial that involves patients who have either wild type or hereditary disease. They have to have a pretty significant disease in that their biomarkers in their bloodstream called the NT-proBNP has to be above 600. They have to have symptomatic disease beyond a diuretic, and patients in this trial get randomized to take this infusion or placebo. I don't know, they don't know, and it's 2 to 1, meaning out of every 3 people, 2 get the active therapy and 1 gets placebo. Patients in this trial are allowed to obviously continue to take their stabilizers. So if you're on tafamidis or acoramidis, those are continued, they're not discontinued. You can't take a silencer in this trial because a silencer does the same thing that the gene editing is doing, but more permanently. Next up, Margie. And this is the depleter trial. I'd love to tell you could enroll, but as you can see in red, it's already fully enrolled. We've enrolled more than 1,000 patients in 13 months around the world. And this is an antibody that, again, activates the cells in the body, hopefully to chomp up or remove amyloid. I think you can see from the pictures up top, there's a patient who got the drug. There's a very dark circle in the middle of their chest that indicates the cardiac uptake. And then at 4 months, you can see later, there's much less uptake in the chest, presumably less amyloid, and then at 12 months, even less. And you might say, what happened to the patient down below? That patient got placebo for the first 4 months. So there was no change in the uptake in the heart. And then they were switched over to active therapy and things improved. And this trial, again, don't have to talk about inclusion criteria, but as you can see, the trial's enrolled patients who were pretty sick with NT-proBNPs over 2,000. The previous trial was 600, and there are reasons that the sponsors chose to do that. But the good news about this trial being fully enrolled so quickly, we thought it would take 2.5 or 3 years to get everyone in, is that we'll probably have an answer about whether this drug is effective sooner than we thought. Next up. This is an interesting study. Everyone on this call, I think, has already been diagnosed, so probably not terribly relevant to you right now. But if you were diagnosed, about 85% of the patients are now diagnosed without the need for a heart biopsy by what we call a PYP scan or a HMDP scan. And these are scans that we helped develop years ago. They're widely used throughout the United States. Hundreds of thousands of them are done. And the scan I showed you on the previous slide was a patient who had uptake in the heart and had amyloid. We've learned that that scan is good, but it's not very sensitive. So out of 100 people who may have much earlier disease than we used to see in the past, only about 70 out of 100 will be positive by the PYP scan, even though they all have amyloid, meaning we could miss up to a third of patients or 30%. And this is a new isotope in which it's a small peptide. Peptide is a bunch of amino acids. There are actually 19 of them, and they are highly negatively charged. And amyloid happens to be a protein that's highly positively charged. And so the two kind of like a battery, meet together, a cation, anion, or like Velcro or, a zipper. This protein can bind to any type of amyloid, AL, TTR, other forms of amyloid in the body and anywhere. In this circumstance, you can see on the right is a figure of different patients who have very yellow appearing circles in their chest. That's the uptake of the isotope in the heart. And we just completed a study that was a pilot study at Columbia in which we took 25 patients. Some of you participated who either did or did not have amyloid. And a classic finding in the study is shown in the bottom where you can see there's a patient who has like a X-ray image and in panel A, there's uptake in the sternum, that's the bones and the ribs, but there's no uptake where the heart really is. And by PYP scan, the standard test, which is shown in panel B and C, there is really no uptake in the heart. But in the same patient, you can see in panel D, there's clearly this blue uptake that's in the heart. So here's a patient who had a genetic form of amyloid. All our scanning tests would suggest he didn't have amyloid, and it turns out he does. And this patient actually went on to get a biopsy. We diagnosed him with amyloid, confirmed it, and he went on to get treatment and now wait, God forbid, for the disease to progress. This trial is determining whether or not what we found preliminarily in a few patients at Columbia is true at a 20-center study around the US, in which we believe this test will be more sensitive and highly specific for finding amyloid. That would be good for new patients. And you might say, well, how can it help me if I already have disease? We think this would be a very good way to quantify and measure based on the isotope sticking onto the heart how much amyloid there is, and then to follow that over time. And so once the agent is approved for use in the US, which we hope would be in the next few years, maybe two, being optimistic, then it could be something we could use to monitor patients over time, addressing, I think, one of the common questions, which is, how's my amyloid? Is it getting better or worse? We don't have very good techniques to measure that. So that's the excitement here. Next slide. And then I mentioned this already, the ACT Early study. This is, like it says, a study in trying to prevent amyloid using the agent Attruby or acoramidis, which is a stabilizer. This is in patients who carry a genetic form of the disease, and trying to administer the drug to try to prevent the development or onset of amyloid rather than wait for it to develop. And we're excited about this study for those patients who unfortunately have a genetic form of the disease, and they're not yet, thankfully, symptomatic, and who are interested in trying to prevent the condition. So we'll see how this works out. This is just started, and as of today, around the world, they're trying to recruit several hundred people, but there's only 6 enrolled. So it's very early in this particular study. Next up. Obviously, with the advent of lots of different therapies, which is great and fantastic, and we're really happy about them, there are a lot of questions that we tried to summarize in a recent article that we published. And many of those are highlighted here. What is the first therapy I should take? Is one better than another? Should I switch from one therapy to another? Should I combine therapies? Are all these therapies in the long term safe? There aren't many asymptomatic patients on this call, and these decisions are very complicated. Unfortunately, these drugs are not cheap, and so that sometimes factors into what insurers will pay for. And we don't have any comparative data comparing drug A to drug B in a clinical trial. So we have to try to look at the data that we have and give you our best recommendations. And those are very individualized in discussion. So today we can't tell an individual person on this call what they should take, but I'll explain to you why we're struggling a little bit, and what information we have. Next slide. So these are the 3 agents that are approved for transthyretin amyloid, whether you have wild type or hereditary disease. The next line of the number of people who participated in the studies. These are not very big studies in the world of cardiology. Sometimes we study tens of thousands of patients. They're all under, 1,000 and a few hundred. And you can see when the studies were done. We started the ATTR ACT trial in 2013, so a decade ago or more. And so things have changed and evolved over time. You can see the age of the participants, in my opinion, hasn't changed very much, gotten a little bit older. The number of patients that we're able to enroll who have genetic disease, unfortunately, has gone down, which is not a good thing. But what has happened, which is great, is even the group in these trials that got no therapy, got placebo, they had a lower chance of passing away. And that's because we're identifying people with earlier stage disease, which is really great. And the placebo, what we call a cardiovascular event rate, that's how many times, God forbid, someone would be in the hospital or would have a morbid event, is also declined, such that it used to be 7 out of 10 people had an event every year. And now less than 30% of patients have an event every year. And the New York Heart class has improved. You can see a significant percentage. Years ago were class 3, 32%, and that's down to less than 9%, or 10%, I should say. And the biomarker NT-proBNP, which is a surrogate of how stressed the heart is, has also gone down. So all of those are good things and makes us a little concerned about telling you, well, one drug's better than another, because at some points in time, the patients who are enrolled are like comparing apples and oranges. They're very, very different patients, which makes cross-trial comparisons very complicated. Next slide. And that's kind of shown here. Just to orient you, this is curve. These are what we call survival curves. So at the beginning of a trial, at time zero, at the bottom, you can see, zero. Everyone's alive. 100% of the people, thank goodness. And then over time, unfortunately, people pass away. And in each of these trials, there are differences between the placebo and the active therapy group. That's not the point. But if you looked at the brown placebo group in the tafamidis ATTR ACT trial, that's the worst curve there, you can see that at 30 months, 42% of the patients had passed away. If you look at the green, light green in the attribute trial, you can see that there's much less. There's now only about 22% of the patients not getting any treatment. Just, so what is the difference? We're finding people earlier. And Helios B, which is the light blue one, also is even better. And so this is the dilemma that we try to explain to each patient individually, which is, the trials are recruiting very, very different people. And so we're struggling to try to give you accurate information about, what we know definitively about whether a drug is better than another. Next slide. So this is a little complicated, but maybe I can walk you through it. What we calculate during these studies is what's called a hazard ratio. A hazard ratio is a ratio between what happens to the group that gets the drug of interest versus the placebo. And if the hazard ratio is 1, the ratio of the two groups is 1, then there's no difference between the outcomes in those two groups. If the hazard ratio is below 1, let's say in the first group, the tafamidis is 0.7, that means that there's a 1 minus 0.7 would be 0.3, or a 30% lower chance of dying in the trial if you took tafamidis compared to placebo. So very effective drug, reduces the chance of passing away. And below that is what we call the 95% confidence intervals. So the bigger the study that we do, the larger the study, the more certain we are of the results, and the narrower those confidence intervals get. The confidence intervals are like, well, if I did this study 100 times over, how many times would I get a result that falls within this particular range? 95 out of 100 times, I would get a result that would suggest that tafamidis could reduce mortality as much as 49%, which is 1 minus 0.51, which would be 0.49, or as little as 4%. So there's a range in that. And you can see for acoramidis, there's a reduction in mortality, and for vutrisiran. And the confidence intervals are sometimes wider. And as a result, they're overlapping, meaning we can't say one drug is better than another unless the confidence intervals are not overlapping. So what we can say is that all three drugs reduce mortality, all three drugs by about 32 to 50% reduce the chance of having a cardiovascular event. And then we can look at the difference that someone walked at the beginning of the study and at the end of the study in their 6-minute hall walk. And you can see what the difference is between the group that got the drug or not. And you can see for tafamidis, it's 75. For acoramidis, it's 40 meters or some odd. And for vutrisiran, it's 27 meters. The reason that the numbers are different, in my opinion, is because, again, there are less sick people in the particular trial. And so the group that didn't get therapy declines less. And so the differences are less. But the upshot of all these numbers is that they're all effective at reducing mortality, cardiovascular events, your decline in your walking test, and your quality of life. But all the confidence intervals are very, very overlapping. There is some data to suggest in the test tube that acoramidis or Attruby, the new stabilizer that Margie mentioned, which is dosed twice a day, might be by some tests better in the test tube at stabilizing the protein. And you can see that shown in what's called the FPE assay, in which the more stable the protein is, the higher the percent stabilized. And there are other studies using a different assay that don't suggest that. So in the test tube, there's some argument to be made that tafamidis might be a better stabilizer than, acoramidis might be better than tafamidis. But what I think patients and we as clinicians are interested in is living longer, feeling better, functioning better. And we don't have data to compare those two directly. Next up. So, I think we'll, at this point, open it up for questions. We tried today to highlight, I think, all the really new developments in the field. It's been a whirlwind in a brief period of time for medicine, getting busier and busier with all sorts of trials. And I know we all have individualized conversations, but I wanted to try to present the perspective broadly. Unfortunately, I think that this still remains a rare and under-recognized disorder. And so the chance that we're going to have at some point head-to-head comparison data between one drug and another in a clinical trial is unlikely. And it may be that we will only have a real-world data, what happens to patients, to kind of inform what's going on. Karan, anything to add before we open it up for questions?
No, I think you summarized it very nicely. We can ask any questions, and happy to answer and engage with everyone.